Welcome to the beginning of Chapter 5, our gastrointestinal system. This week we're going to look at some of the components of the GI system and some of the pathologies of the upper GI and small bowel. So to get started, we're going to look at our objectives. You can read through these and we will get going on our next slide. Okay, first of all, we're going to discuss the physiology of the gastrointestinal system. So the basic function of the gastrointestinal system is to alter the chemical and physical composition of foods through a number of different activities and digest and absorb those nutrients. So some of the things that our digestive system, some of the actions our digestive system takes is mastication, which occurs in the mouth, and that is from the chewing process. And it uses both kinetic or mobile energy of the grinding motion of the teeth, as well as the chemical component of the saliva in the mouth to help start the initial breakdown of food. The next part is the process of swallowing, and that is called degglutination. When degglutination occurs, the tongue and a number of different muscles in the face and neck are all involved in pushing that food bolus down the esophagus. And the esophagus is going to travel down the mediastinum to the diaphragm. And when it crosses that diaphragm, it empties into the stomach at that cardiac sphincter. The stomach portion is going to have a number of different rugae, and it is going to produce peptic acid and other components to help break down that food material. Now, the stomach also peristalsis and moves around the food. And so again, it's providing a chemical and a emotional component that will help produce or help get the food to the next stage of digestion. After that, it goes into the duodenum, which is the first part of the small intestine. This is where a large portion of the absorption of our nutrients occurs. It's in the duodenum that we see the entrance of the common bile duct from the gallbladder. The common bile duct empties the gallbladder's bile into the duodenum, where that bile can assist in the breakdown of fats. From there, it goes through the small intestines. Throughout the whole small intestines, the walls are made up of these cilia-type cells. And those cilia-type cells increase the surface area of the small intestines, allowing for better absorption of the food. Once it reaches the end of, it goes through the duodenum, jejunum, and then the ileum, the third component of the small bowel. Once it gets through the ileum, it's going to go into the large intestine. The sphincter that it goes through to enter the large intestine is called the ileocecal valve, and that valve allows the small intestine food to move into the large intestine. And here it travels up the ascending colon, across the transverse colon, down the descending colon, into the sigmoid colon, and then out into the rectum, and finally the anus. The whole digestive system together is called the alimentary canal. Okay. Now, really, our small intestines were involved in a lot of that absorption of nutrients. If it's made it to the large intestine, then that's where a lot of our water absorption occurs. And that's where people can get constipated if they're not taking enough water into their system. Patients that end up with diarrhea, on the other hand, are moving fluids or moving materials too quickly through their small intestines into the large intestines, and then the large intestines do not have enough time to resorb that fluid. So that's when patients will experience diarrhea. So the functioning of the GI system is going to be dependent on secretion of the endocrine and exocrine glands, and that can be multiple different glands, such as our salivary glands, our pancreas, and other endocrine glands. The movement of food through the GI tract can allow for resorption of different materials and nutrients in different sections of the bowel. So we're going to start looking at some of the pathology of the esophagus. So the first one we're going to look at is the Tracheoesophageal Fistula, then esophagitis, then ingestion of corrosive agents, esophageal cancer, esophageal diverticula, esophageal varices, hiatal hernia, achalasia, foreign bodies, and the perforation of the esophagus. So let's get started with the tracheoesophageal fistula. There's actually multiple forms of the tracheoesophageal fistula. And in the terminology we can see right here, it's going to involve the trachea, the esophagus, and is going to be a fistula, which is an unusual connection between two non-connected tubes. So we're going to have some sort of connection between the trachea and the esophagus. The problem with these is that, depending on the type it is, it'll allow the esophagus, which is taking in food and water, to actually communicate with the trachea, which should only be taking in air. So this would allow food and water to enter the respiratory system and cause something like aspiration pneumonia. Now, there's multiple different types. Most of our tracheoesophageal fistulas are going to be the congenital form, or something that you're born with. These congenital forms usually are a result from failure of the esophageal lumen to develop completely and separately from the trachea. The second type is an acquired type, and this is less common, but it's usually caused by some sort of erosion of the esophagus into the trachea. So things like cancer, infection, trauma, and inappropriate instrumentation can cause that perforation and create an esophageal tracheoesophageal. In our second image here, you see that the patient has another young patient by the bony development, and you can see that this patient has an esophagus filled with contrast, and then you see a little bit of flow from the contrast to from the esophagus to the trachea. So this would be the H pattern tracheoesophageal fistula, when you have two complete tubes and they are communicating with one another. Here's some examples of the different possibilities of esophageal atresia. First, this is your normal anatomy. You have an esophagus, you have a separate trachea, they may maintain separate entities all the way down the tracts. Here's one that we saw in that first x-ray. So we have a esophagus that is esophageal atresia that has a blind pouch at the end, and then the second half of the esophagus articulates or communicates with the trachea. And then as this patient would be breathing in, the air would be going down the trachea into the lungs and into the stomach. So you would see a dilated stomach bubble with air on an x-ray. This example is where you have the esophagus communicating with the trachea, as well as the lower esophagus communicating with the trachea. There is no blunt end, so this does not have any type of atresia because it is communicating into the trachea itself. Here we see a situation where we have esophagus that communicates or has a fistula connection to the trachea, and then we have the lower esophagus with a blunt end. Here we have an upper and lower esophagus, both with blunt ends, so we have esophageal atresia at the top and the bottom. Here we have that H format that we saw on the second image, where we have a full esophagus, a full trachea, but they have a communication between the two. And any of these are possibilities. One thing to note about esophageal atresia and tracheoesophageal fistulas is if it's a congenital issue and it's not addressed, the child would then starve to death. So these need to be surgically repaired immediately. They're also associated with different congenital abnormalities, such as spinal defects and chromosomal defects. That brings us to esophagitis. In our terminology here, we know that esophagitis is inflammation, itis, of the esophagus. So usually esophagitis is due to some kind of reflux typically coming from the stomach. And so this can also be known as gastroesophageal reflux disease, or GERD, which is probably something you're seeing a lot with your patients that come in for upper GIs or barium swallows. And what happens with GERD is that usually the acids from the stomach are able to enter and move in a retrograde fashion because of an incompetent cardiac valve between the stomach and the esophagus. And as that gastric acid comes up into the esophagus, it irritates the esophageal cells, and it can cause, over time, it can cause some changes in those cellular types. Now, as GERD progresses and the damage of those cells cause this squamous epithelial normal cells of the esophagus to change into columnar cells. And as this happens, it can result in some strictures of the distal esophagus. And this is what's known as Barrett's esophagus. Barrett's esophagus is something that's taken pretty seriously because in the existence of Barrett's esophagus, sometimes these cells can further go on to become less and less differentiated and change over time to ultimately become esophageal carcinoma. Now, some other types of causes of esophagitis, other than our GERD and Barrett's esophagus, could be herpes virus or candida. Candida would be a fungal infection. Herpes would obviously be a viral infection. These they would treat less by surgical means and more by treatment of the cause. So an antiviral or an antifungal may allow a patient to resolve this issue. Now, over time, esophagitis will cause irritation to the esophageal lining. And that mucosal lining over time will typically develop large ulcers. So when we're watching a normal functioning, normal anatomy esophagus, and you're watching the contrast move through it, you're going to see typically very smooth, consistent walls. When you see a patient that has esophagitis, you can see disruption of the smooth nature of those walls and with ulcerization. You can also see thickening of the mucus as well. In this exam, we see here a patient that's doing a barium swallow and has esophagitis due to infection. So this would typically be caused by herpes or candida, which again is our fungal infections. And you can see that this has caused inflammation along the whole wall of the esophagus, making that normal striated appearance look almost lobular. And with this, if this is allowed to progress for long enough, again, it can result in Barrett's esophagus and cause prolonged problems. Sometimes we can cause damage to our esophagus by ingestion of corrosive agents. So these would typically be poisons, or a good example is when children get a hold of cleaning materials or something like that, and the ingestion of these can cause significant problems. So the initial ingestion will produce acute inflammatory changes in the esophagus. Depending on how long it stays in the esophagus, sometimes determines the amount of damage that's done. If the fluid or matter is swallowed and moves quickly through the system, usually it's just a very superficial penetration. And with that, you really notice only mild or minimal ulcerations. Now, if for some reason it was maintained in the esophagus for a longer period of time, maybe because it was a thick fluid or they're having difficulty swallowing, or because they have a stricture in their cardiac valve, then it can cause additional problems. When somebody does ingest a corrosive agent, it's important that you contact poison control, and they will typically send you to the emergency room to get a neutralizing agent on top of that corrosive agent and allow it to pass through the system. They don't usually want to induce vomiting because that would simply expose the esophagus to the corrosive agent again to do twice the damage. Okay. Now, deeper penetration or longer penetration will get through the mucosal lining, and it can cause some sloughing of destroyed tissues and deeper ulcerations. If it's there for long enough, then it can corrode through the entire esophagus, creating some type of fistula or a rupture of the esophagus. Esophageal cancer is somewhat common, and it can occur in patients that are higher risk because of smoking or because of long history of GERD or excessive alcohol intake. And usually esophageal cancer is not necessarily demonstrated right away. One of the primary symptoms of this is dysphagia, but unfortunately, by the time the patient is experiencing dysphagia or difficulty swallowing, it's because they're already in late stages of the disease. The most common type of this is going to be, or the most common site of this is going to be in the esophagogastric junction. And the cell types that are usually altered are going to be the squamous cell. So that would be the innermost mucosal lining. And here's an example of esophageal cancer. So you see that it will typically start in that distal esophagus, and then over time it will move up through the esophageal lining. And you see how it definitely disrupts that lumen of the esophagus in this image. Esophageal diverticula are going to be outpouchings of the esophageal wall. They can be caused by, they can either be true or they can be traction. The difference between these two is that true esophageal diverticula is a diverticula that is just a weakening of the esophageal wall, and it allows that wall to outpouch, and food or other debris can get stuck in there. Now, traction diverticula is because something is pulling that part of the esophagus outward. You can have false or pulsion diverticula as well. So false diverticula is going to be composed of only the mucosa and the submucosa, and then there's going to be herniation through the muscular layer. Whereas with true intraction, they're going to involve all layers. Here's an example of a Zenker's diverticula, and you see it here with a nice outpouching in the cervical or thoracic region. Esophageal varices are very fascinating. These are dilated veins in the distal esophagus, and they can sometimes be appreciated on your barium swallows, but usually it's going to be in the later stages of the disease. Now, the causes of esophageal varices really ties back to portal hypertension. So when we look at all of the connections of the portal system, our portal system, for a quick review, involves the portal vein and the liver. Here's the liver. Our portal vein takes deoxygenated but highly nutrient-rich blood into the liver. Well, where does it get that deoxygenated, highly nutrient-rich blood? Well, the portal vein is the combination of the splenic vein and the superior mesenteric vein. The splenic vein is bringing deoxygenated blood back from the spleen, and the superior mesenteric vein is bringing deoxygenated blood back from the bowels. And that superior mesenteric vein, as it dropped off all of its oxygen to the bowel, it picked up all of the nutrients that were housed within that bowel. So our portal system comes in as a vein, our superior mesenteric vein from the bowel and our splenic vein from the spleen. They combine and they move into the liver through the portal system. Now, that portal system is going to divide into different branches, and it goes throughout the liver. And next to the portal system runs the hepatic artery. So I'm going to put the hepatic artery here is going to be purple. Now, the hepatic artery comes off of the aorta, and it delivers oxygenated blood to the liver. Now, 80% of the blood flow to the liver is from the portal system, and only 20% comes from the hepatic artery. So 20% of the blood's oxygenated, 80% is not, but it's highly nutrient rich. And so this is able to come in, and together they're really able to bathe that and provide nutrients and oxygen to all those really important hepatic cells. Now, if you have somebody that's done long-term damage to their liver, either through chronic viral hepatitis or maybe alcohol's hepatitis, then you're going to see the normal, nice round cells of the liver, the hepatocytes, you're going to see them start to get sick. And at first, they're going to be inflamed. And after inflammation lasts so long, they begin to kind of shrivel up and harden up and get replaced by fibrous tissue. And as that happens, your liver begins to degenerate and turn into this lumpy, bumpy, hard little organ. Now, as it does this, that blood from the portal system that used to just flow right in, be absorbed into the liver and move on its merry way, all of a sudden it can't get in there very well anymore. So that hardening and fibrosing of the liver is called cirrhosis. Now, when the cirrhosis occurs, it makes it very hard for that portal system to introduce blood into the liver. And because it's so difficult, that blood can't be emptied into there, it's going to back up into this portal system. And when it backs up into the portal system, it's going to back up into the superior mesenteric vein. It's going to back up into the splenic vein. And it is going to back up into the esophagus because the esophagus is not going to be able to deposit its blood in the IVC directly anymore because of its location to the liver. The liver gets hard, it disrupts the blood flow of the esophagus into the liver, and then those esophageal veins begin to dilate and get distended, hence causing varices. So with some of our patients that come in with esophageal varices, they might be vomiting up blood. Usually this is going to be a sign of a very late stage portal hypertension due to cirrhosis. And there's no cure for cirrhosis. So I know that's a very long, convoluted discussion on how that happens, but by understanding by understanding cirrhosis in the process of portal hypertension, it really describes a lot of the pathologies that we encounter in the abdomen and as we see with the esophageal varices in the thoracic systems. Here's an example of esophageal varices. So these veins of the esophagus are supposed to be coming down here and draining into the abdomen and into the IVC here, but because of that disruption due to cirrhotic liver, it's backing those up, and you see that the dilated veins are displacing the barium in this barium swallow, causing them to appear as esophageal varices. And this patient would be very sick with liver disease, and they'd probably be vomiting blood. That brings us to hiatal hernias. Now, hiatal hernias are a herniation through the crux of the diaphragm, right at the central diaphragm where the aorta, IVC, and some of our nerves pass through. So when we have a disruption of the diaphragm at that area, where our diaphragm is really in charge of holding all of our abdominal contents below the diaphragm and all of our thoracic contents above the diaphragm. And when we have a hiatal hernia, it is allowing abdominal contents or organs to move through an opening in the diaphragm up into the thoracic cavity. Okay. It's typically the portion of the stomach that's allowed to get through this area. Now with this, these can be really difficult to identify, but when we're looking at our lateral chest x-rays, if you see a mass containing air posterior to the heart, hiatal hernia is a significant differential diagnosis. Okay. Now the degree of that herniation is going to vary widely. So sometimes if it's a very small herniation, it wouldn't be something we could appreciate. But larger herniations we are able to appreciate well. Now because of the constriction around, if my diaphragm's coming in here and my stomach is protruding halfway above the diaphragm and halfway below the diaphragm, that can really affect a patient's ability to swallow and move the food and drink into the stomach. It's going to get blocked up here at the level of the hernia. Because of this, sometimes you'll have gastroesophageal reflux disease because it cannot get through this narrowed opening. So GERD is very common with your hiatal hernias. If these aren't significant, most of the time they won't address them, but if they're causing the patient significant problems and causing them GERD specifically, then they might go ahead and do an intraoperative repair. Now, the reason we're really worried about GERD is, remember, that gastric reflux over time can change the cellular lining of the esophagus, which could eventually lead to cellular changes in cancer. So here's some great examples of esophageal hernias. Here you see a barium or an upper GI. Barium is going down the esophagus. It reaches the fundus of the stomach, and then you can see the stomach is very constricted here. You also see that this is the diaphragm right here, and the fundus of the stomach is above the diaphragm. So this is indicative of a hiatal hernia. Here on this CT, we have the heart here, the liver here, And behind the heart, we see this outpouching that is not typically there. That is demonstrating a hiatal hernia. Okay, achalasia is an interesting abnormality. This is where you have a functional obstruction of the distal esophagus right before it enters the stomach. Now, usually this is caused by some nerve damage. So usually our nerves make our muscles contract. It makes our orifices open and close. And in achalasia, some nervous problems or some nerve problems at the area of the distal esophagus causes it to have incomplete relaxation, allowing food to move from the stomach here from the esophagus here into the stomach. So you see how this backs up food into the esophagus and would cause a lot of that feeling of heartburn. And it causes a stricture, so very little is getting through to the stomach. Again, that's a nerve problem, so the opening and closing, the muscular contractions in that area are not functioning well. And they're going to cause a lot of heartburn type symptoms. Okay, another thing that we can look at in our upper GI system is we can evaluate for foreign bodies. So this will typically occur with children, although I've imaged many adults that have foreign bodies in their airways. Foreign bodies, depending on what they're made of, are going to be radioopaque all the way to radiolucent. The radioopaque ones are very easy to see, and you never need the aid of contrast to see those. Radiolucent ones are difficult to see, and really they're best seen when we utilize a barium swallow, and that barium would move around the radiolucent object and cause it to show its outline, and that's how we would identify a radiolucent object. When we're identifying foreign bodies in the upper gastrointestinal system, we want to take two projections 90 degrees from one another, so either a PA or AP plus a lateral, and that's going to determine if the object is truly lodged in the esophagus or if it could possibly be in the trachea or external. Here's an example of a radioopaque foreign body lodged right here, so no contrast necessary to see that. Most of the time, the best approach for those foreign bodies, they'll usually try to get them to pass through the patient rather than try and do a removal. But for some particular items, they may recommend a removal. There was in the news a few years ago a little girl in Oklahoma that swallowed a watch battery and nobody knew she had. And that watch battery didn't pass. It sat in her esophagus for so long that it actually ate. The acid ate through her bowels, perforated arteries, and she bled to death. So in cases like that, they would certainly want to surgically remove something, but if it's something like a coin that can pass through and not cause any damage, then they'll probably just allow that to go through. Okay, perforation of the esophagus, the example that I just gave of the little girl with the battery would cause a perforation of the esophagus. Other things that might cause a perforation of the esophagus could be some types of trauma, an instrumentation or something like a scope, a neoplasm that weakens the wall, a deep ulcer, or long-term esophagitis that would keep that wall so inflamed that it would eventually deteriorate. Some of the perforations can result from severe vomiting, and this is especially associated with alcoholism. So there's already some weakening in the system typically, and by very, very violent vomiting, sometimes the pressures can cause rupture or perforation of the esophagus. And here's an example of esophageal perforation. This patient has an NG tube, as you see. They have put contrast into the patient's stomach through the NG tube, but you see some of that contrast is actually coming out of the esophagus from external to the stomach. Okay, and here again you see a bolus of material coming out of the esophagus. Here's the aorta fully intact, and you're seeing something come out of the esophagus here. All right, which pathology is defined as development anomaly in which the esophagus ends in a blind pouch. This is atresia, when you have a lumen or a tube that just comes to an unexpected end. It's referred to as atresia, and this is associated with esophageal or tracheoesophageal varices. Which pathology is a result of failure of the lower esophageal sphincter to fully relax? This we just spoke about, it's achalasia. So this is a failure of the nervous system that will not allow that esophageal sphincter to relax. Okay, that will move us into some of our stomach pathology. So with stomach pathology, we're going to look at gastritis, which is inflammation of the gastrointestinal system, but specifically the gastric area or stomach. Pyloric stenosis, which anytime we see the terminology stenosis, we know that that means narrowing. Pyloric is going to be that muscular region at the distal end of the stomach that allows stomach or gastric materials to go into the duodenum or first part of the small intestine. We'll look at peptic ulcer diseases, cancer of the stomach, and lymphoma of the stomach. Gastritis, just as the name tells us, is inflammation of the stomach, and it's specifically inflammation of the mucosa. This can be caused by a number of different things. It can be caused by alcohol or corrosive agents, so irritants that inflame those cells, or it can be caused by infection. And one of the common infections that cause gastritis is the H. pylori bacteria, or Helicobacter pylori, better known as H. pylori. And this is a bacteria that over time can just irritate the stomach constantly, and cause some significant ulcers. Just a side note on this, my whole family thought that they had really bad acidic stomach, and in my dad, when he was about 50, he actually passed out. He ended up in the ER. They realized that he had internal bleeding from an ulcer, and after living with ulcers in his stomach for whole 50 years of his life, he found out that he had H. pylori. They were able to treat it with antibiotics, and he's never had this problem again. But he was sick most of his life with ulcers in his stomach, and until it almost killed him, they never realized that it was a simple bacteria that could have been treated all those years before. So it's just one of those stories you can kind of relate to about how this can really affect people's lives. So H. pylori can cause chronic gastritis that can lead to peptic ulcer disease, and when you get significant peptic ulcers, they can be deadly because that's a highly vascular region, and if one of the ulcers ulcerates into a major vessel, then it's going to cause a lot of internal bleeding. Now, when somebody has gastritis, one of the things that you will notice, especially utilizing contrast, is that it's going to change the normal surface pattern of the gastric mucosa. So we're used to seeing the gastric mucosa, especially in our double contrast upper GIs, we're used to really being able to make out the rugae in the stomach. And somebody that has gastritis is going to have altered rugae. As you can see on this patient with gastritis here, it differs from your typical double contrast upper GI because we usually in those exams or images, we're going to see nice linear rugae. And here in this image, you see that the rugae seems more serpentine and deeper. And that's one of the signs that indicate gastritis. Now, pyloric stenosis is something that we really need to identify very early on in age. Pyloric stenosis typically affects infantile males. So this is something that really needs to be identified early in life. So what happens with these infants is that typically they're going to be male, and lots of times they will be born and their mothers will be trying to feed them, and they will just have consistent projectile vomiting. So every time they drink some milk, they'll vomit it up. And of course, this makes them feel very fussy because they're hungry. And so with pyloric stenosis, there's going to be failure to thrive, which means failure to gain weight, and they're going to be very fussy, and they're going to have this, this projectile vomiting. The causes of this is that those muscular layers of the pyloric region, so if we look at the stomach, our stomach looks something a little bit like this. A little bit like this. I know it's a poor image. And we come to a sphincter here that opens and closes in and out, or opens and closes the distal end of the stomach and allows food to move into our small intestine or our duodenum. Now, this sphincter is known as our pyloric sphincter. If this sphincter overgrows or hypertrophies, it will be so big that it will not be able to allow fluid into the duodenum. So what it ends up really looking like is this big, thick muscle at the end of the stomach. And this is one of the things that we really can evaluate in ultrasound. And by evaluating in ultrasound, you can put your transducer kind of right above where the pyloric sphincter should be and watch. And if the stomach is filling up with fluid and none of that fluid moves through that pyloric sphincter into the duodenum over a certain length of time, then you have to be very suspicious for pyloric stenosis. The other thing is that there's normal measurements of how thick these muscles should be. And if the muscle measures greater than the normal measurements, again, it's going to be indicative of pyloric stenosis. These really need to be surgically corrected right away so that the baby does not basically starve. Now, that pyloric stenosis can cause complete or incomplete obstruction, so that the extent of the overgrowth of that stenotic fluid or stenotic tissue is going to determine if it lets some or no food and fluids through. And obviously, the complete is going to be a much more urgent surgery than the incomplete, but both of these will typically be surgically corrected. Now, sometimes doctors can find these through clinical evaluation of the patient just by those very significant symptoms that I already discussed, as well as pressing and feeling with their fingers on the baby's belly. They might feel a hard olive type sensation right where the baby's pyloric sphincter would be. Okay, that brings us to peptic ulcer disease. So peptic ulcer disease is a group of different inflammatory processes that involve the stomach and the proximal duodenum. And what these ulcers or peptic ulcers do is they cause action of the acid and the enzyme pepsin secreting in the stomach to react and kind of eat away the stomach's mucosal tissue. The most common location that these peptic ulcers are really going to develop is going to be in the lesser curvature of the stomach, which, if you remember, the lesser curvature, if our fundus is here, the lesser curvature is there. This would be our lesser curvature. So this is the most common place that you'll see these peptic ulcers form. Okay. The disease spectrum ranges from very small and something that might just be occasionally irritable to something that is very significant and, like I used as an example with my dad, can rupture and cause huge bleeds. Major complications of peptic ulcer disease is hemorrhage, gastric outlet obstruction, or perforation of the entire stomach. Peptic ulcer disease is the most common cause of acute upper gastrointestinal bleeding. Duodenal ulcers are also very common manifestation, so it won't just stop in the stomach, it can spread all the way to the duodenum. Many of the duodenal peptic ulcers are going to occur in the duodenal bulb. So if we look at the anatomy, and here's my stomach, and this is my duodenum. The duodenum wraps around the pancreatic head, something like that, and it's right in this area, the duodenal bulb, that you'll typically see these peptic ulcers. So here is a peptic ulcer of the duodenal bulb. So you're able to see the outline of the duodenum here, and it's coming along pretty regularly, and then all of a sudden you see this outpouching here. That's going to be a duodenal ulcer. It looks somewhat like a diverticuli, and yet it's going to have tissue that lines out, and the erosion is just going to be at the center of the tissue, whereas a diverticuli would be just an outpouch. Now, if this occurs in the gastric region, it can look something like this, where you'll have that outpouching and then you'll have these folds of the stomach all radiating out toward that ulcer. Okay. Now, anytime you have something like peptic ulcer disease or any other chronic irritants of the stomach, you're going to be at higher risk of stomach cancer. Other things that are going to increase your risk of stomach cancer are other things that keep your cells of the stomach upset. So one of the most common things that does that is alcoholism. Now, cancer of the stomach is more prevalent in Japan, Chile, and parts of Eastern Europe. The unfortunate thing is that they usually don't have a lot of pain, so lots of times they're not going to get diagnosed with stomach cancer until it's already metastasized to other regions of the body and it's too late to really treat the patient. So because of that, late diagnosis, prognosis for cancer of the stomach is typically pretty poor. Some of the other things that predispose you to cancer of the stomach is atrophic gastric mucosa, which means that mucosa in the stomach lining is going to be underdeveloped. And because it's underdeveloped, it often is more susceptible to cancer. Usually 10 to 20 years after a partial gastrectomy for peptic ulcer disease, people will still end up passing away. Okay, so here's an example of gastric carcinoma, and this is called by that the underdevelopment of the mucosa. So you see you have nice rugae here. The mucosa is developed. The reason that rugae is so important is that it increases the surface area of the stomach and allows for better absorption. But down here in the distal stomach, pyloric region here, you're seeing that you lose all of that rugae, and that's due to underdeveloped mucosa. And over time, that's become cancerous or gastric carcinoma, and it's really taken away that rugae appearance of the stomach. That brings us to lymphoma of the stomach. And whenever we talk about a lymphoma, you really have to take in the terminology here. Lymph is our lymphatic system. Our lymphatic system is a part of our immune system, and it also helps with circulation. So as we have our arterial and venous system that goes out through our body, we usually have most parts of our arterial and venous system is followed by a lymphatic system. And the lymphatic system has lymph vessels and lymph nodes, and it helps clean up some of the mess that can be floating out around our body and help address some infective processes. As it does this, it also helps when fluid gets left out in tissues from the venous and arterial supply. It helps pick up those excessive fluids and return them to circulation. So it really has a significant role in both preventing significant swelling in our systems as well as in our immunity system. Now, when you get lymph cells from that lymph system that are malignant, because that lymph system travels all over the body, these lymph cells can end up anywhere. Gastric lymphoma is usually seen as a large, bulky, polypoid mass, usually irregular or ulcerated, and it can be indistinguishable from general gastric carcinoma. So it would take a biopsy to determine whether lymphoma of the stomach was just a carcinoma or if it was lymphoma. So a quick summary of our findings of the stomach. Gastritis is inflammation of the stomach. It can be caused by alcohol abuse. And when we see that, we see a changing of the gastric folds or rugae with a thickened gastric outlet, with thickened gastric folds and a gastric outlet obstruction. If we have a corrosive gastritis, this is from swallowing something that was corrosive to our mucosal lining, like a poison or some sort of cleaning solution, and this will typically appear as a narrowing of the antrum. So just proximal to the pylorus is our antrum. If that narrows, that's going to be indicative of corrosive. And then we have our bacterial and infectious gastritis, which often leads to ulcers. Finally, we have our chronic atrophic gastritis, which means that we have underdeveloped mucosal cells, and so we'll see unusual appearing mucosal folds. Then we talk about pyloric stenosis, and this is a narrowing of the pyloric sphincter, which is caused by a hypertrophy or an overgrowth of the pyloric region. That overgrowth is going to cause that sphincter to be overreactive and not allow fluid to move through the stomach into the duodenum. This can cause, it will be seen in infants, typically males, and it can cause projectile vomiting, failure to thrive, a lot of fussiness, and it needs to be treated with surgery. Okay. Peptic ulcers are usually caused by an issue with the acids in our stomach eating away at the mucosal lining, causing an inflammatory process and a degeneration of the ulcerative area itself. We see these as small shadowing erosions all the way to perforations. And we can identify them on upper GIs, CT, or sometimes on MRI. Okay. Sometimes we can see a gastric ulcer, which we know usually occurs in that lesser curvature of the stomach. Some of these these are typically benign, but some can actually be malignant, and it's almost impossible to differentiate the benign from the malignant. But if we do recognize a difference in the two, we see that the benign usually has some smooth and slender folds that extend to the edge of the crater, whereas the malignant will have those same types of folds, but they will extend to a mound outside of the crater. Okay. Superficial gastric erosions. Lots of times this is something that's just detected on an area where a fleck of barium or a radiolucent halo will be noted on an upper GI. Then we have our gastric cancers. So there can be a couple different types. You can have a polypoid mass, where just the mass begins growing out of the mucosal wall out of control, and that creates a cancer. Or you can have a gastric wall infiltration, where some cancer comes, reacts with the wall, and then starts diffusing itself into the wall. And when these do occur, there's typically need for surgical resection of all or part of the stomach. And again, this isn't typically, it doesn't typically coincide with pain, so lots of these will be missed until it's too late. Okay, so gastric cancer is one of the most common cancers in the United States. That is actually false. It was more common in Eastern Europe and Japan. All of the following are complications of peptic ulcer disease except hemorrhage, gastric outlet obstruction, perforation, or GERD. Our answer here would be GERD. Okay, this will bring us to small bowel pathology, and we will cover that next week. So thank you for your patience with this. I hope you get something out of the lecture, and we'll see you next week. Have a great day.